Good morning, everyone. So today we are going to see about the hip joint. Okay, the anatomy of the. Okay, so we will also in the next session I will be describing about the knee joint. The ankle joint will be covered up at a later time. We all know that the hip joint is a ball and socket type of joint, and the bones which articulate in the hip joint is the head of the femur. So this is the head of the femur and the acetabular fossa. The acetabular fossa, you know that it's made from the three bones ilium, ischium, and pubis. The whole joint is covered by the capsule. It is covered by this capsule. Here you can see the capsule covers the entire hip joint and is attached along the margins of the acetabulum and the neck of the femur. Okay, you can see that it's getting attached to the neck of the femur. There are many ligaments which help in strengthening up the hip joint. Some of them are as follows. So, you know, there are three bones which forms the hip bone, ilium, ischium, and pubis. There is a ligament which comes from the ilium to the femur, which is the iliofemoral ligament. There is another ligament which comes from ischium to the femur, that's the ischiofemoral ligament, and other ligament which comes from the pubis to the femur. So that's the pubofemoral ligament. So what are the main functions of these ligaments? These ligaments, they prevent overextension during standing. So what happens when you are extending your hip joint? Okay, so the overextension is prevented by these ligaments. Okay, the iliofemoral, the and the ischiofemoral. Apart from preventing overextension, the pubofemoral also helps in limiting the abduction. Okay, limiting the abduction. So here you can see from the pubis, the pubofemoral ligament is coming up. Okay, the pubofemoral ligament. So this is the iliofemoral ligament. Iliofemoral ligament can be seen from the posterior aspect coming from the ischium towards the femur. Here you could see this. So this is ligament of the head of femur. Okay, the ligament of the head of. Okay, so what is the importance of this? So you can see that this ligament is the main ligament which holds the acetabulum and the head of the femur in its place. Also, you can see there is an artery which passes along this ligament. Okay, so which is called as the artery to the ligament of the head of to the head of femur. Okay, and if this artery is cut, okay, for example during a hip fracture, okay, so the head of the femur can go in for avascular necrosis. Okay, so vascular, you know, there is blood supply. Avascular, no blood supply. Necrosis, dead. Okay, the dead tissue. Okay, so avascular necrosis of the head of femur can occur if these ligaments are torn, thereby impairing the blood supply to this part of the head of femur. The entire hip joint is a synovial joint, you know that, and it is lined by the synovial membrane. There are many bursas which surround the hip joints. So here are some of the few bursas. One of the most important bursa is the psoas bursa. So you can see that psoas bursa. So this is situated below the iliopsoas muscle. Okay, below the iliopsoas muscle, which is a strong flexor of the hip joint, and the ilio and pubofemoral ligament. So between this there is a bursa. Okay, so then there is an inflammation in this bursa. The person can complain of pain during flexion of the hip joint. Okay, so there will be pain during the flexion of the hip joint. The nerve supply. The nerve supply to the head of femur. The nerve supply to the head of femur is by the following nerves, which is the femoral nerve, the obturator nerve, sciatic, and the nerve to quadratus femoris. So basically, the nerve supply follows the Hilton's law. So Hilton's law, you know that. So the muscle that crosses the joint also supplies the joint. So in the anterior aspect, you know that the quadriceps, they are supplied by the femoral. The medial aspect, the adductors, they are supplied by the obturator nerve. Posteriorly, the hamstrings are supplied by the sciatic nerve, and the lateral rotators by the nerve quadratus femoris. So these are the nerves which crosses the hip joint. They also supply the hip joint. Now let's see what are the muscles which help in the various actions of the hip joint. First, let's look in the flexors. Okay, the flexors of the hip joint. So iliopsoas is the major muscle which is involved in flexion of the hip. Now, if you observe the hip flexion, when the knee is flexed, the person is able to flex until the abdominal wall, until he hits the abdominal wall. Whereas when the knee is extended, okay, he cannot flex beyond a certain angle. Why is it due to? Because when the knee is flexed, so he is able to do a full flexion. He is able to do a full flexion. Whereas when the knee is extended, okay, it has been limited by the hamstring muscle, which is on the posterior region. Okay, so the posterior region, the hamstrings, so they prevent further extension, further flexion of the hip joint when the knee joint is extended. What are the muscles which involve in extension? So mainly it's the hamstrings and the gluteus maximus. And we have already seen that the overextension has been prevented by the three ligaments, ilio, pubo, and ischiofemoral ligaments. Abduction. Okay, abduction, the main muscles is the gluteus medius and minimus, and it is limited by the pubofemoral ligament. You cannot extend beyond a certain point because of the pubofemoral. It is mainly by the gluteus medius and minimus along with the tensor fascia lata, limited by the ischiofemoral ligament. Okay, so these are the muscles which help in various movements of the hip joint. Now let's see some of the important correlates, some of the clinical significances of the hip joint. A pain in the hip joint can be referred to the front and medial aspect of the thigh. You know what is a referred pain? Referred pain is when the pathology is the hip joint, the patient may complain of pain elsewhere. So a person complaining of pain in the front and medial aspect of the thigh, okay, so you need to think of a hip joint pathology. Why there is a referred pain? It's because they both are supplied by the same nerve, which is the cutaneous nerve of thigh. Okay, intermediate and medial cutaneous nerve of thigh, which are branches from the femoral nerve. The knee joint. Okay, a person complaining of pain in the knee joint suspect a hip joint pathology because a hip joint pathology can be referred to the knee joint. How is it possible? Because it is both supplied by the same nerve, which is the obturator nerve. Okay, the posterior division of obturator nerve. Okay, they supply both the hip as well as the knee joint. So thereby the pain can be radiated to the knee joint. Another clinical condition is the congenital dislocation of the hip. Dislocation, you know that the head of the femur is not lying in the acetabulum, so that is the dislocation, congenital right from birth. Okay, so why this is due to? It's because of the development failure of development of the acetabulum. So here you can see the acetabulum, the bones are not fused. This is not the fracture line. Okay, so here you can see the acetabulum, and this is the head of the femur. Okay, the developing femur. Whereas on this side, you are unable to see the acetabulum more clearly. The acetabulum is still not yet fully formed in children. Okay, so in infants and newborn, it's not fully formed. Okay, it's still growing. The hip bones are not yet fused. Okay, so here you can see the acetabulum is not fully formed, as well as the head of the femur is also not form. Okay, so as a result, there is a dislocation of the hip. Okay, so how can we identify this? Clinically, we do certain tests, okay, which are newborn checks. So where we check whether the head of the femur is located is present. Okay, so by doing a slight abduction, okay, and adduction. So there are specific names which are given to this test, so which we will learn when you go to the pediatrics posting. Okay, so these tests are conducted to check out if there is any congenital dislocation of the hip. By means of X-ray, you can also find out. So that's by using this important line, so which is called as the Shenton's line. So the Shenton's line, it's a line. If you draw a line on an X-ray from the obturator foramen, okay, and it should coincide with the curvature of the neck of femur. Okay, so here you can see it is coinciding, whereas on this side, okay, so the curvature of the obturator foramen is here, whereas the neck, it is located somewhere here. So there is an irregularity or a breakage in this Shenton's line. So that can indicate that this is a case of dislocation of the hip. So this Shenton's line can also be used for diagnosing the any fractures in the neck of femur. Okay, so as well as any dislocations. Okay, so this is a very important line, so which we can by which we can detect any dislocations by using an X-ray. The other dislocation of the hip, especially in adults, so it's a traumatic one, an acquired dislocation of the hip. The most common is the posterior dislocation of the hip. Okay, so but dislocation of the hip as such, it's very rare because the hip is a very strong joint, you know that. Okay, because it's a ball and socket type of joint. Okay, so it's very rare, but it can occur, especially in a case of a dashboard injury. So here you can see when a person suddenly applies the brake, the dashboard can hit the femoral condyles, and the force can be transmitted to the shaft of femur, and it can snip away from the acetabulum, leading on to posterior dislocation. So in this case, you can see that the head of the acetabulum is chipped off and the femur goes into the posterior compartment. So you know that the posterior compartment is extensor, so the person will not be able to do any extension of the hip joint. So as a result, here you can see that the person goes in for has got a specific posture. You can see the hip joint is slightly flexed and adducted and internally rotated. Okay, so flexion, adduction, and internal rotation. So that's in case of posterior dislocation of the hip. Okay, so that's in the posterior dislocation of the hip because the head of the femur, it goes into the extensors. So the extensors cannot they cannot function. As a result, the flexors, they will act more, as well as the adductors. So leading on to flexion, adduction, and internal rotation. Now, the component there, because the head of femur goes into the extensor compartment, sometimes there could be a damage to the sciatic nerve as well. So this was already covered to you, covered in the muscles of the thigh. Okay, the stability of a joint, the hip joint, when a person stands on one leg. So that mainly depends not only on not only because the femur is located within the acetabulum because it is a ball and socket type of joint, and also by the neck of the femur and the normal angle with the shaft of femur. Okay, so these are the components, and the other most important one is the gluteus medius and minimus. So these four components are the ones which help in a person to stand on one leg. Okay, to stand on one leg. Okay, so if this is any one of this is damaged, the person will not be able to stand on one leg. Okay, so here you already know that if there is a head of femur Okay, any a dislocation, definitely the person cannot stand. Any fracture neck of femur, of course they cannot stand. Okay, if the angle with the shaft of femur, okay, the neck and the shaft of femur, if the angle is disrupted, okay, so then also the person will not be able to stand. How to detect the gluteus medius and minimus? So that's where we use the Trendelenburg sign. So here you can see if a person has to lift the leg, the opposite side gluteus medius and minimus should contract. Okay, the opposite side gluteus medius and minimus should contract so that the pelvis is tilted. Okay, and the person is able to lift the leg. Okay, so if he is unable to lift the leg and if he falls off, okay, it means that the opposite side gluteus medius and minimus is not not working. What is the most common mode of injury? So it's because of injury to the superior gluteal nerve. So how is this nerve getting affected? Most commonly by means of uh, intramuscular injections, faulty intramuscular injections. That's why when giving gluteal injections over the gluteal region, you need to take care to give the injections on the upper outer quadrant of the gluteal region. Okay, in the upper outer quadrant of the gluteal region. Okay, so need to take care so that the superior gluteal nerve is not injured. So if it's injured, the gluteus medius and minimus can be paralyzed, leading on to the person unable to lift the leg on the opposite side. So with this, we come to the end of the hip joint. So in your next video, I will be describing about the knee joint. Thank you.